Hello, I'm Dr. Elliot Brinton. I'm past president of the American Board of Clinical Lipidology. I'm president of the Utah Lipid Center in Salt Lake City, Utah. And I'm delighted that you're joining me for Module 1 of the National Triglyceride Alliance program, Hypertriglyceridemia, Basic Pathophysiology. We have some educational objectives. We're going to review the prevalence of high triglycerides across the entire spectrum of elevated triglycerides. We're going to talk about how triglyceride levels are modulated and controlled by the body. We're going to talk about adverse consequences of high triglycerides. We're going to talk briefly about treatment. A lot of this module 1 is just kind of introductory. We're going to send you into greater detail with other modules, but I think you're going to like this module because it gives us a quick overview of this field. So what is the triglyceride distribution in the general population? It's very broad. Here we have just a quick overview of the distribution of triglycerides in the US population. And what we see is that 2/3 of the folks are less than 150. We're not going to talk about them. Another 1/3 nearly are in the 200 to 500 range. And we call that mild to moderate hypertriglyceridemia. And then there are just a few that are severe HTG, maybe 2% of adults. And we're going to talk about them in some detail. They are the ones that we focus on a lot, but we also want to focus on mild to moderate as well. There are roughly 18 mild to moderate high triglyceride patients for every one with severe. So that's kind of an interesting perspective. So here we've got a continuous graph. We're looking at men on the left, women on the right. You can see that men have higher triglycerides. There's less in the green, more in the yellow, more in the red. Women on average have quite a bit lower triglycerides. There's some race differences, especially Hispanics, people of Native American origin, also East Asians and South Asians are distributed more to the right, tending to have somewhat higher. Of course, Caucasians and Blacks on average have a little bit lower, but of course, many of us have high triglycerides and severe hypertriglyceridemia as well. Let's take a more careful look at that extreme end, and we're going to change the orientation of the graph here. And we're going to look in a little bit of detail above 1,000. You see that in the inset there. 1,000 is one of two cutoffs for chylomicronemia. 1,000 is a nice round number in milligrams per deciliter. You may hear 880 milligrams per deciliter, which is 10 millimoles. So either cutoff is fine for chylomicronemia. You'll see the terms FCS and MCS. We'll talk about those in just a minute. But this distribution within the extremely high chylomicronemic range is interesting because even though we think just of FCS, you know, the monogenic, biallelic, genotypic proven disease, realize that that's very rare with triglycerides above 1,000. It's about 1 out of 1,000 folks with triglycerides over 1,000, chylomicronemia. And if you think about this for a minute, about 8%, 9% or so of the folks who have this pure chylomicronemia, they're always chylomicronemic, they actually have not FCS, but what we could call MCS. It's not genotypic proven FCS. In fact, 88 times more likely to have this non-FCS than FCS if you've got your chylomicrons over 1,000. Wow, that's interesting to keep in mind. So we've got several terms here, the true genotypic FCS. We've got clinical or functional FCS, similar but not genotypically proven, okay? We've got MCS, multifactorial. We've got another term that overlaps called EHTG, or extreme hypertriglyceridemia. Another new term, I really like this one, called persistent chylomicronemia, where a majority of the triglyceride measurements, fasting or non, we try to measure them fasting as we'll discuss later, but a majority of those fasting triglycerides are over 1,000. That is persistent chylomicronemia. And that is a new term that we're going to talk about in a later module. These are all overlapping and a little confusing, but I just want to introduce the terminology to you. So what are the pathways? What are the mechanisms of triglycerides? Well, let's start with the liver, upper left. It makes VLDL 24/7. The small intestine, lower left, makes chylomicrons when we are absorbing fat, which is usually for, I don't know, an hour or 2 or 3 or so after a meal, after a fat-containing meal. And then the chylomicrons and VLDL are lipolyzed. The triglyceride is removed by LPL. That's central to this figure here. And that happens very rapidly. LPL in most people is extremely efficient, extremely rapid. And within a matter of minutes, the VLDL or the chylomicrons that come into the circulation become remnants because LPL in most people is so effective. Now, what do those remnants do? Well, one place they can go is to the liver, hepatic lipoprotein receptors. That's very important because we want to get rid of these remnants because they are atherogenic. So let's look at the atherosclerotic plaque. What is it doing? Well, it's not only receiving LDL or Lp(a), it's receiving VLDL and chylomicron remnants. That's bad news. This is why we have this connection of even very high chylomicronemic patients with elevated risk of heart attack and stroke. Do we have help? Yes, we do. We have ApoA5. It travels with VLDL and chylomicrons. It helps LPL do its job. This is all good news. If those lipoproteins are not cleared by the liver, they go to the plaque. So we want to upregulate those receptors. Maybe ApoC-III inhibition helps a little. That's a teaser for a later module. Now let's look at this with the inhibitors. We've got ApoC-III. That's a big and bad inhibitor of lipoprotein lipase. It also inhibits direct uptake of the remnants by the liver. So ApoC-III is a bad guy. We want to inhibit him if we can. And as you'll see a little bit later, we've got one new agent and another on the way that's going to help us with that. Meanwhile, we also have two other factors, and these are new kids on the block. We haven't hardly scratched the surface with them, but ANGPTL3, ANGPTL4, they don't circulate, but they're on the wall of the artery and the veins, and they are helping to inhibit lipoprotein lipase activity. Ouch. So if we inhibit them, does that help? The answer, of course, is yes. So we have reducing LPL activity, which is bad news, loss of function of ApoA5, gain of function of ApoC-III, loss of function of LPL or LPL-related factors. That's bad news. The good news on the right-hand side here is an increase in LPL activity with a gain of function in LPL. That's pretty rare. Maybe loss of function of ANGPTL3 or 4, loss of function of ApoC-III. Those are fairly rare. But again, if we inhibit those, then they will help lipoprotein lipase gain in function. That'll lower triglycerides, lower risk of not only CVD, but also acute pancreatitis. So what about measuring triglyceride levels? Well, most of what we know about triglycerides and other lipoproteins are done in fasting samples, overnight fast. And yeah, that's inconvenient, but it works well. And remember, when we're talking about research data, study data, guideline data, it's usually fasting levels, fasting data. So we've got studies of non-fasting triglycerides. That's great. But we see patients one at a time. These studies of thousands of patients, are they relevant? Yes and no. Remember that there's a lot of lipoprotein variability, especially in triglycerides at the very bottom here. And so let's say we want to measure non-fasting. Well, we know that lipoproteins and triglycerides postprandially are atherogenic. Okay, so if we eat a low-fat meal, we get maybe a 20% rise in triglycerides. If we eat a higher fat meal, we can get 50% or more of the increase in the triglycerides. So we're 20 to 50% higher than we were fasting, but we don't know how much higher, right? Because who knows when it is that we're absorbing and how much fat did we eat and when did we eat? All these questions that we don't know. How fast did it come out of the stomach? And so we're introducing a 20 to 50% noise. And of course, triglyceride-lowering drugs are generally in the 20 to 50% range. So signal-to-noise ratio is 1 to 1. We're in trouble, I think, with non-fasting triglycerides. I really like the reproducibility of an overnight fast. It does give us an indication of postprandial risk. Why? Because the fasting levels are higher when the postprandial levels are higher. There's a parallel change there that is very valuable. I want to measure fasting glucose in my patients. Why? Because I do a lot of metabolic syndrome, and fasting glucose is one of the 5 elements, as is fasting triglycerides. So 2 of the 5 elements of metabolic syndrome require overnight fast. It's easy to do if we plan it ahead of time. We know the patient's coming in, ask them to come in fasting a week or so before the visit. That way we have a fasting level, but we also have results ahead of time. When I see my patients, I want to say, here's what your levels are now, rather than we'll talk later sometime about your levels that we take this afternoon. I don't like that. I want to have shared decision-making with current data with my patients. So except for a few rare exceptions, you want to do a fat tolerance test, go for it. But we really want to measure triglycerides fasting. Now let's talk just a minute more about the remnants. We've mentioned them already. Here you see the size of the remnant particles and their density, and that's shown in the test tube on the left. You see the remnants shown in red in the middle. But I want to point out that there's a lot of controversy, a lot of lack of information about chylomicrons. And I've got a lot of text here on the right of the slide, but my point is that we don't yet have a consensus method for measuring remnants accurately. And a majority of the papers that we have about remnant lipoprotein cholesterol are in fact simply a calculated VLDL cholesterol. And the way you calculate VLDL cholesterol is you divide triglycerides by 5. So we're back to triglycerides. So remnant lipoproteins are interesting. We can measure them if we want to, but as a general rule, it's not very helpful beyond just the standard lipid panel and of course with a non-HDL that helps capture that risk. So what's the relationship between triglyceride levels and acute pancreatitis? This bar graph, I think, is very dramatic because it shows very little change between 150 and 500 triglycerides. And you go above 500, there's a huge increase in acute pancreatitis risk. So we call this severe hypertriglyceridemia. This is where we must focus our efforts on prevention of acute pancreatitis. So now the question is, well, if somebody has a triglyceride of 600 fasting, why does that translate into acute pancreatitis risk? Remember that if you do a fasting sample and you tell the patient ahead of time, that's the lowest their triglycerides are ever going to be. What about a weekend with some nachos and some alcohol and their triglycerides are higher, and postprandially most of the time they're higher. So somebody with a fasting triglyceride of 600 could easily be 1600 or 2600 in their native state most of the time, right? So you catch them fasting at their lowest ever, and that's why this relationship seems a little bit unusual. There's a physiology behind that, right? So we've talked about pancreatitis briefly. We'll get back to this later in another module, but let's look at ASCVD. Well, ASCVD risk goes up dramatically above 500. Do we appreciate that? I hope we remember this. And even 300 or 200, the risk goes up, but especially in that severe HTG range. And what about in the lower end? Well, here's some studies looking more carefully at the lower end. And here we're looking at fasting triglycerides in the 70 or 80 up to 200 range. Again, a big increase. So triglyceride elevation at any level can contribute substantially, hugely to ASCVD risk. Please remember that. Please keep that in mind. And this is true even if the patient's on a statin. Here on statin data from a statin trial. Just going above 150 gives you about a 50%, 40% increase in risk of ASCVD. Wow. So even with LDLs controlled and statins on board, you have to look at triglycerides as a risk factor for ASCVD, and we're going to talk about that in some other modules in more detail. So what are the mechanisms? Let's just touch on it briefly in module 1. If we look at it here, we've got VLDL and IDL, and we've got triglyceride exchange to LDL. So triglyceride goes into LDL, cholesterol goes out of LDL into VLDL and remnants. And so those chylomicron remnants and VLDL remnants all have a lot of cholesterol that is largely donated from LDL. Well, that makes them more atherogenic. But at the same time, we're doing something else very important. As cholesterol leaves and triglycerides enters the LDL particle, then either lipoprotein lipase or hepatic lipase, shown here, will remove that triglyceride very rapidly, shrinking the LDL. So small dense LDL is a natural product of hypertriglyceridemia. And small dense LDL is more readily able to enter the artery wall. It's stickier, it's more readily oxidized, it's more atherogenic. So shrinking your LDL, which is what folks with high triglycerides do 24/7, is harmful in terms of atherogenesis independent of triglycerides per se. Now, triglyceride levels all by themselves also can be atherogenic. Why? Triglycerides, as they come into the artery wall, and they do come in on all the lipoprotein particles, are lipolyzed. And that lipolysis produces free fatty acid. Free fatty acid is very pro-inflammatory. And remember, you don't have albumin like we do in the circulation. That buffers free fatty acids out there in circulation. In the artery wall, we don't have it. And so the free fatty acids are very pro-inflammatory, which is pro-atherogenic. So there are several mechanisms by which even just a little elevation of triglyceride can result in a rather large increase in ASCVD risk and atherogenesis. Let's touch briefly on the basics of hypertriglyceridemia treatment. Statins are first. Well, why? Because of what I just told you, there's a risk throughout the continuum of 150 up to 15,000 of ASCVD risk, and statins are just the best for reducing ASCVD risk. They do reduce risk very nicely, very dramatically in patients with high triglycerides. So we know this works. And we should always use statins in just about everybody. If you know for a fact somebody has FCS, don't bother, because they do not have an elevated risk of ASCVD. But we'll get back to that in another module. What about diet? Well, you've got to do diet. Low sugar, because sugar drives hepatic production of VLDL. It's mainly the fructose. And remember, high fructose corn syrup is just a little bit worse than regular regular sugar, which is 50-50. The other is 55-45. So fructose and sugar just drive VLDL production by the liver. That causes trouble, as we've just discussed. Fat, of course, is problematic for patients with chylomicronemia, so they've got to reduce that. And then alcohol drives VLDL production and inhibits LPL. And so we want to be either low or no ethanol for patients with hypertriglyceridemia. We do, of course, want to try to do exercise. That will help reduce it as well. We want to treat secondary causes. Obesity and diabetes are 1 and 2, and we want to control them as best we can. That's hard to do, but that's super important. Other things like hypothyroidism, oral estrogens, various other things we need to look at and try to address as best we can. Primary treatment with triglyceride-lowering agents, we have fenofibrate and omega-3s. We'll talk about that in a subsequent module. And we've got this exciting new class of ApoC-III inhibitors, one already approved, another coming soon. We're going to talk about that more in detail, but you can see from what I told you about ApoC-III how those might help. And then we have triglyceride goals in chylomicronemic patients. Yes, less than 500, that's when you're out of the danger zone for fasting triglyceride down below there. Get it there and keep it there, and the risk of acute pancreatitis becomes much lower. We have goals for the other folks, not yet. The triglyceride and ASCVD thing is so complicated that we don't have firm and fast goals there. This is just a showing of the secondary causes. You can see this in the wheel. These are just pictures of the things we've just discussed. So you've got the genotypic thing, which is mainly for the folks with true FCS. And then you've got all these other factors that are important in MCS, which is basically everything but the genotypic FCS. And that would be true like for persistent chylomicronemia. We're not going to treat the genes, we're going to treat the secondary factors. So to summarize, mild to moderate hypertriglyceridemia is common and it increases ASCVD risk. Severe hypertriglyceridemia, chylomicronemia, extreme hyperchylomicronemia, whatever term you want to use, it is uncommon to rare, but in most cases, the vast majority, the risk of ASCVD goes up, but that's, of course, where we see the risk of acute pancreatitis. And the risk of acute pancreatitis is there regardless of the genotype and secondary factors and this persistent chylomicronemia. It's all there. We're going to get into that with a later module. Postprandial triglycerides are important, but we are not recommending spending a lot of time measuring remnants or trying to treat them because we're just not there yet. Triglyceride levels are always best measured after an overnight fast. All hypertriglyceridemia should be treated. And we use statins first, and we go to the management of secondary factors, and then we have primary treatment with triglyceride-lowering agents. And I want to thank you. It's been a lot of fun. I hope you've enjoyed Module 1.